In today's lecture, the goal of today's lecture is basically to take everything that we learned in the past week or so and build on it and show to you how the basic understanding of molecular things of biochemistry can help you in basically understanding how to treat your patients. So we're going to talk about chemicals, about drugs, about medications that bind to the receptors that we talked about. They influence their function in various ways, and we're going to talk about how these individual drugs, what effects they have in the body, and how they're used clinically. Okay. Now, some of you may have noticed that this used to be 2 lectures, but unfortunately we had to compress it into 1 because there was a dean's order that said that we have to do it. So we won't be able to go through everything that I would otherwise like to talk about. All the information can be found either in the 2 handouts that you have on Vyuka. And I also today I posted the old video of the 2nd lecture as well. Okay, so this lecture was basically spread out into 2, and there was a little bit more content. So both of these videos are now online, the old ones. So if you want, you can have a look at them as well. Yes. You don't need to see both the videos, but you need to know all the information. Okay? So the basic information that is essential for passing the test is in the 2 handouts. Okay? So if you know that stuff, you're fine for passing the test. Okay? It may be helpful to look at the other video as well, because I spent a bit more time talking about some of the things. Okay? But you don't have to if you're fine with just learning the facts from the tables. Okay? Right. Okay, so today's lecture is going to be about groups of drugs, about groups of medications, and with each group I'm going to tell you about the mechanisms of effects, what they are, what they do. It is going to be a little quicker than you used to, and there will be a lot of new names, but all the names, all the new things are summarized in the handouts. So even if you miss something, you don't actually have to write down the new names or whatever, because they are all written down for you in the handouts. Okay, so don't spend time with that and oh, I can't actually read it properly. It doesn't matter. Okay, all the important new names are in the handouts. Okay, just try to listen and try to get the basic principles and what goes on. Okay. The first group of drugs, of medications I want to talk about are local anesthetics. What do local anesthetics do? What they're used for? Yeah. Who said that? Yeah. What was that?
The relief of pain.
Okay. I mean, relief of pain, usually that I would connect with analgesics. Okay. Anesthetics, they just block the perception. They block the perception of pain. I know it sounds like the same thing, but it doesn't sound like the same thing to me. Okay. So relieving pain when you have your, pain in your knee or something, you wouldn't use a local anesthetic for that. You would use a painkiller, basically. Okay? But a local anesthetic usually used for procedures, for operations or whatever they just block the perception of pain. In fact, they actually block completely the nerve conduction in the area that has been anesthetized. Okay? Both the perception and usually the motor function as well. Okay? So when something is anesthetized, usually you can't even move it. Okay? So it's a complete blockage of nerve signals, depending on the dose, but usually it completely blocks them. So local anesthetics, what are the other kind of anesthetics as opposed to local ones? General anesthetics, okay? The difference is that while local anesthetics, as I said, just block nerve conduction in a specific part of the nerve, general anesthetics block the perception in the brain, on the central level, okay? So your nerve conduction is not affected, or not seriously affected, during general anesthesia, but your perception, you're basically unconscious and you don't feel the pain, okay? For a local anesthetic, it's a different mechanism, right? Yes?
Is that what you mean by the difference between anesthetics and the other thing you said, that even though you can't
yeah, well,
pain muscle, can react
that's
to the
Yeah, I mean, that's even a separate group, okay? So analgesics, they specifically, more or less specifically, block just the perception of pain. So after a local anesthetic is used, you won't feel touch, you won't feel any other sense, and you won't be able to move your finger if it's anesthetic usually, okay? With an analgesic, it only blocks the perception of pain, and that's always centrally mediated. Opiates are typical analgesics, okay? So they work on the central level and they just work against pain. Anesthetic, actually the name says it, it actually blocks all perception. Aesthesis in Greek just means perception, or maybe Greek speakers could correct me, but basically it's more general, okay? Anesthetics just block everything, okay? Now, what is the mechanism of effect of local anesthetics? Well, since we want to block all nerve conduction, the best target that we can use are voltage-gated sodium channels, okay? Remember that voltage-gated sodium channels are absolutely essential for any kind of action potential in any kind of nerve cell. If we block them, we block action potential conduction, and therefore we block any conduction of signals through a nerve, right? Does it make sense? Does it make sense? Okay, good. So local anesthetics block voltage-dependent sodium channels. The original local anesthetic was cocaine, well, is still, but that was the first one. Cocaine. It was the first one that was discovered, probably a long time ago, I would imagine, because the first people who started using coke leaves probably noticed that that's an anesthetic. And indeed, cocaine binds to sodium, to voltage-dependent sodium channels and blocks them. Now, this is not the activity why cocaine is abused, okay? So this is a separate effect. Cocaine actually has several different molecular targets to bind to, and this is just one effect that cocaine causes, okay? Cocaine was used as a local anesthetic for a very long time, but obviously, since we all know that it has addictive potential, its use declined over time, and there were new derivatives, new chemicals that had the same effect in the local anesthetic area, but didn't have all the other effects that cause addiction and that make people abuse cocaine. Okay? But just one second, all the new ones tend to end, their names tend to end with cane, so that they still refer to this original cocaine. So you may have heard about lidocaine, about procaine, I think that's actually spelled with K, etc. There are lots of novocaine, okay? Lots of different new molecules that chemically are actually not very closely related to cocaine. They do the same thing in the, so they also block sodium channels, but the names still refer to the original one, to cocaine. Yeah, you had a question?
Is there any chance of dependency or addiction with local anesthetic use?
No, absolutely not. That's what I'm saying, okay? So all these new ones do not possess the other set of effects, the other set of molecular targets that cocaine has. And we're going to mention, hopefully, at least some of them in the lecture, okay? So there's absolutely no risk of addiction with all the new ones, okay? Cocaine is still used to some extent as a local anesthetic, especially in ear, nose, throat area, okay? So ENT. Because it has some very advantageous properties, because it also stops bleeding, because it contracts blood vessels, it constricts blood vessels, so it also decreases bleeding. So it's very useful for certain kind of applications. But because of all the other problems, it's a controlled substance, it's very difficult to import, etc., etc. Cocaine is now basically not used in medicine almost at all, okay? Just very few areas, okay? Yeah, there's a question?
Was cocaine injected for like local anesthesia?
No. Usually it's used for a mucosal anesthesia. So basically you just wash the mucosa, like in your nose, for example, with cocaine, and it makes it numb. Okay, so as far as I, well, yes. So as far as I know, it was never injected. But yeah, that was actually a question the Czech students. There was a question the Czech students had. Well, one of them, if it actually, if you snort it, if it makes your nose numb. So anyway, I guess some of you know. All right. just to put it into perspective, we talked about another sodium channel blocker in one of the previous lectures. Which one was it? It was tetrodotoxin. Okay. The difference between tetrodotoxin and the local anesthetics is that while tetrodotoxin, this is a sodium channel, tetrodotoxin binds from the outside and blocks the pore. These local anesthetics all bind from the inside, which is quite interesting. So first they have to diffuse into the axon, and then they bind to the ion channel from the inside, which also poses some limits to their structure, to the structure of these molecules, because they at least have to have a form which is not charged, so that they can diffuse through the membrane. Okay, they are actually, all of them or most of them have amino groups that can be charged or can be uncharged, and they have to, in the uncharged form, they have to get into the axon, and then they can bind to into the pore. Yes.
It says here that both the local anesthetics and the tetrodotoxin block by binding the intercellular.
I'm not sure about that. Do I say that?
Yeah.
Well, then either then or now I'm wrong. Okay. Okay. But there are many other toxins that also bind, so it may not be tetrodotoxin, but there are many, and actually most of the toxins bind to the outside. Okay. So thanks for correcting me. If I say so, then it's probably true that tetrodotoxin also binds from the inside. But many of the other ones, the scorpion toxins, etc., bind to the outside. Okay. The important thing to get from this, however, is that local anesthetics bind from the inside. Okay, that's the reason why I mentioned it at all. Okay, there was another question. No, I thought there was. No. Okay, right. Local anesthetics. The Czech students ask me, well, are there any side effects if you give a local anesthetic? Because obviously some of the local anesthetic has to get out of the area which you're trying to anesthetize, and they will get into circulation. Do they cause any other problems? Like, do they cause paralysis of muscles elsewhere? Well, generally they don't, because the concentrations are very low. Because imagine if you want to anesthetize a finger, you only inject a very small amount to block the nerve that comes out of the finger that carries the signals. So the amounts used are very low, and also the binding depends on whether the fibers have myelin or not. But I'll just say that local anesthetics do have another effect outside of nervous system, and that's in the heart. Because the heart, similar to nerves, it depends on sodium channels, on voltage-dependent sodium channels, in order to conduct the signals between the cardiac cells. Okay, so blocking these receptors, you can slow down the conduction of signals inside the heart as well. For that, you have to use higher concentrations. You have to inject them into the bloodstream. But in fact, many of these, or several of these local anesthetics, especially lidocaine, are used as anti-arrhythmic drugs. Okay, so they're used to treat arrhythmias. When the conduction in the heart is not working properly, you can use lidocaine to slow it down and to improve the arrhythmia. Okay, so same molecular target, but in different tissues and therefore different use. Okay, yes.
Do they have like different levels of times of reaction? Like I know.
Yes. Yes.
It takes like 30
yes.
seconds or
yes.
something.
You have very short-acting local anesthetics and relatively long-acting, and that just depends on how long they stay in one place, how long they are carried, how fast they are carried away by the bloodstream. So there are several different factors that determine how fast-acting or how slow-acting these anesthetics are. Okay. Yes, you're right. They do have differences. Okay. Any more questions about local anesthetics?
This site 1 of sodium, voltage-gated sodium channel, isn't that the extracellular side? Like,
What do you mean by site 1?
I don't know, it's called site 1.
Okay.
No?
Yeah, I don't know what site 1 is.
If it is, then tetrodotoxin it binds to the extracellular.
Okay.
Yeah.
Well, you can discuss that afterwards. Okay. Yeah. My perception was that tetrodotoxin binds to the outside, but if I say that it binds to the inside, it's probably true in the table. But once again, That's not the issue here, okay? What I want you to remember is that local anesthetics bind to the inside, because that's important for the structure, for their pharmacological properties, okay? That's the important bit, okay? Whether tetrodotoxin binds to the outside, inside, I don't care very much, okay? Good. So moving on to the next group, which is still somewhat related to nerves and muscles, we're going to talk about muscle relaxants, okay? We're going to talk about drugs that can relax our muscles. Very simply said. Muscle relaxants. Now, muscle relaxants can be divided into several groups. Okay, there are several ways to categorize them. And I will divide them into central and peripheral, and then we'll subdivide those as well. The central muscle relaxants basically act, as the name suggests, act in the central nervous system, and their role is, what they do in the central nervous system, they potentiate the inhibitory neuronal circuits, okay? So at a very high level, they basically inhibit the activation of your skeletal muscle, and hence they decrease the tone, which we feel as relaxation, okay? Does it make sense? No, okay? So the tone, all our muscles are basically constantly, if we are conscious, if we are alive, are constantly under certain tone, so they have certain tension in them all the time, okay? You may not feel it, you may feel, okay, there's no tone, but actually, if you compared it with a, well, I don't want to say with a dead person, but especially with somebody in very deep coma, you would see that even your relaxed hand has more tone than the person in a very deep coma. Okay, so there's a certain amount of tone. And this muscle tone is regulated both at the level of spinal cord and in the brain. Okay, so there are neuronal circuits that determine how much, basically, tension there is in your muscles. Okay, and we can influence this tension by using centrally acting myorelaxants, or muscle relaxants, which act on the most important inhibitory neurotransmitter receptors, which are GABA. Okay. And we can use both GABA A and GABA B receptors. Are we going to use agonists or antagonists? Yeah, we're going to use agonists, okay? So we're going to potentiate the GABA transmission, and therefore we're going to inhibit the activation that goes into our muscles. Does that make sense? Because I can see that some people are a bit confused by that.
An antagonist of GABA would do the opposite.
Exactly.
Not inhibit the X.
Indeed, and they can actually cause spasms, muscle spasms, okay? So correct. Antagonist would do the opposite. There was another question at the back?
Yeah, so we have the central nervous system.
Yep.
And it controls the skeletal muscle.
Yep.
The brain and spinal cord.
Yep.
We use drugs that inhibit GABA A, GABA B to...
No, that activate GABA A, GABA B. Okay, yes?
Excuse me, when you just said that an antagonist does the opposite effect, does the antagonist do the opposite effect, or is the inverse agonist the one that does the opposite effect?
Okay. When I say that it causes the opposite effect, I mean it causes the opposite effect when you inject it to a person. At the level of a cell, it will obviously not do the opposite effect. It will just stop GABA from doing its thing. Okay? So there is all the time, there's some level of GABA transmission. Okay? All the time, those synapses are in our working brain are releasing GABA. Okay? And this release of GABA can increase or decrease, whatever. If we use an antagonist, we block the existing GABA transmission, which keeps our muscles basically at equilibrium, you know, not spasming, but not completely flaccid. Okay? Yeah, so that's how it works. I think there was something else. No? No. Okay. The GABA B agonist, specific GABA B agonist, is called baclofen. Baclofen. Again, it's all in your tables. You don't have to write it down. For GABA A is a very interesting receptor because it can bind a lot of different things. Okay, it's sort of a multi-receptor because a lot of different drugs bind to them. Okay, The group of drugs that I want to talk about here are benzodiazepines. Benzodiazepines. And probably the most famous, well, I guess, the most famous representative of the group is diazepam or Valium, those of you who know the proprietary name. Okay, just terminology-wise, each drug has a proprietary name, so that's the name if you go to a pharmacy and ask for it. But more important, especially for the lower years of your studies, is what is called a generic name. Okay, so generic name just describes the substance. Okay, diazepam is a generic name. It identifies a specific chemical substance. Okay, Valium is a proprietary name. So a certain company sells diazepam as Valium. Some other company sells it as what have you. Okay, I don't know all the other proprietary names. Okay, so the ones that we're interested in are the generic names. So there's just one name for it, diazepam. Okay, and it can be sold under various other proprietary names. Okay, just to make that clear. Right. So benzodiazepines. There's a knee there. Benzodiazepines, diazepam being one of them, but there are probably 20, maybe 50 of various benzodiazepines. They all bind to GABA A receptors, potentiate the transmission on that. So they act as agonists on GABA A receptors. Okay, and we'll talk about them later on because they also have, through GABA A, they have other effects than just muscle relaxation. Okay. So these two muscle relaxants cause what I just described as muscle relaxation. They decrease muscle tone. You can use it when people have spasms, muscle spasms in their back or something like that. Okay, so not a serious cramping, but basically just you need to decrease the tone to help the, yes?
Can you use them like for cough medicine as well? Like
No. No. You would have to probably use a very high dose where the people would basically be unconscious. So no, there are other ways. There are other ways of doing that.
Are they?
Yeah.
Are they addictive?
Yes, they do have an addictive potential. Yes, you have to be careful. Not baclofen, but benzodiazepines they do. Yes. Yeah.
Do they act as GABA, or do they act as a GABA molecule?
Do they act like it, or
Like the same way?
well, they bind to the receptor. Actually, they bind to a different site on the receptor. Okay, I don't want to go into massive detail, but the GABA receptor is a huge channel, and there are several different binding sites. Okay, benzodiazepines bind to a different part of the receptor. They're basically allosteric agonists. Okay, but you don't need to know that. All right, right. So these are centrally acting, central myorelaxants, but when we look at peripheral muscle relaxants, you will see that those have a very different, much more dramatic effect. Okay, peripheral muscle relaxants act on the neuromuscular junction. Okay, so from a very high level of regulation of muscle tone, we go all the way down to the lowest possible level. Okay, the neuromuscular junction. And what peripheral muscle relaxants do, they basically block the transmission of signal between the nerve and the muscle. So unlike the centrally acting ones, they just make you feel more relaxed. Peripheral muscle relaxants make you completely paralyzed. No movement at all. Okay? Not even your breathing muscles. Okay? So if you give peripheral muscle relaxants to a patient, you have to artificially ventilate them. They will not breathe. Okay? So all skeletal muscle is basically knocked out by those. Okay? Quite a different effect between the two groups of myorelaxants. Okay? Yes? No? Okay. The peripheral myorelaxants can be divided into further two groups depending on the mechanism of effect. The first one are non-depolarizing, and obviously the other ones are depolarizing. Depolarizing. Okay? Now what's the difference? The non-depolarizing muscle relaxants, peripheral muscle relaxants, do a very simple thing. They block nicotinic acetylcholine receptors in the neuromuscular junction. Okay? So they just block the receptors, acetylcholine receptors. If they are blocked, whatever signal comes to the neuromuscular junction, it cannot be, transduced into the muscle, and there's no muscle movement. As simple as that. Okay, clear? Non-depolarizing, just block nicotinic receptors.
They block the receptors on the...
They block the receptors. Okay.
All receptors or only nicotinic?
Specifically the nicotinic acetylcholine receptors in the neuromuscular junction, because there are actually different types of nicotinic acetylcholine receptors. Okay, so they are quite specific for that. Some of them are more specific, some of them are less specific. But okay, so they block nicotinic acetylcholine receptors in the neuromuscular junction. Okay, the prototypical non-depolarizing muscle relaxant, peripheral muscle relaxant is curare, which you've probably heard of. It's the poison that was used by Amazonian, well, it probably still is, by Amazonian Indians to kill animals, okay? How did it kill them? Well, because they stopped breathing. Well, first they stopped running, and then they stopped breathing, okay? So a very, very potent molecule. Now, curare contains a lot of various toxins, and the most important one is tubocurarin, which is the active substance. Now, today we have many other derivatives of curare. Once again, they differ by the length of their effect. So we have very short-acting and very long-acting relaxants, depending on the use. What would we use these for? What are the situations where we want to completely paralyze a person? Apart from trying to kill them or something, but yeah?
For example, abdominal surgery?
Yeah, absolutely, okay? Various kinds of surgery, abdominal surgery, or even orthopedic. When you do a hip replacement, you want to completely relax the muscles so that you can get in and do your stuff. Okay. For the abdominal surgical procedures, even though the patient is under general anesthesia, they still have painful reflexes very often. Okay, because the coma that is caused by the general anesthetic is not deep enough. So if you start cutting into their intestines, usually they unconsciously, but they react to it, okay? So if you completely relax them, you don't have that problem. It's much easier to operate. But you have to ventilate them because they can't even breathe, okay? So that's a typical use for a peripheral muscle relaxant. Yes?
Any concentration will cause like complete knockout?
Of course not. Okay? If you give them just one molecule of curare, nothing will happen. Okay, so it depends on the dose, of course. Yes?
But usually the concentrations used are for the whole body?
Yes. Okay. The other derivative, the newer derivative that I want you to know, which is actually a short-acting one, is pancuronium. It's a positively charged molecule, pancuronium. Yeah. Okay, let's have a look at the depolarizing muscle relaxants, because that's something that is a little bit counterintuitive. So while the non-depolarizing sort are antagonists on nicotinic acetylcholine receptors, the depolarizing ones are agonists on nicotinic acetylcholine receptors. Okay? So we have antagonists and agonists used for the same purpose. Okay? So that is probably quite counterintuitive. So let me explain. Remember when we talked about the action potential in an axon, we said that the sodium channels they become, throughout the action potential, they become inactivated. And then in order to be, once again, able to activate, the potential has to return to normal. So the cell has to repolarize so that the voltage-dependent sodium channels can open once again. Otherwise, they're just closed and remain closed, right? Does everyone remember that? Okay, the same is actually true not just for the sodium channels on axons, but it's also true for sodium channels on the muscles. And it's also to some extent true, at least for some groups of calcium channels as well. Okay, so even in the muscle, we have to depolarize the membrane, and then we have to repolarize it, and then depolarize it again, so that muscle contraction remains constant. Okay, so it doesn't work like that. That basically you just keep, shooting acetylcholine on the muscle, and it continues contracting. Okay, we have to repolarize, depolarize, repolarize, depolarize. Otherwise, it doesn't work. So what the depolarizing muscle, yes?
And just a little question. You said But last course, you said serine. Is that the same way that that affects it because it just produces more acetylcholine?
Yes. Okay. So the nerve gas that we talked about, which is an inhibitor of acetylcholinesterase, the mechanism of the paralysis that's caused by it is exactly the same as here. Okay. So what we do here, we have a long-acting agonist on nicotinic acetylcholine receptors, which in the beginning they cause contraction. But since they cannot be broken down by acetylcholinesterase, or the breakdown takes a very long time, so they stay in the synapse, they stay in the neuromuscular junction for a very long time, they just keep activating the nicotinic receptors. Therefore, they keep depolarizing the muscle membrane. And since it cannot repolarize, at a certain point, all the ion channels close and they don't open anymore. Okay? So all the calcium that was released for the contraction is pumped back into the endoplasmic reticulum, and there is no more. Okay? Because we need to repolarize the membrane again before we can restart the whole process. Does it make sense? Yeah? Not really.
Could you compare it to what happens in the first one again then?
Yeah, so in the first one, what we do is we have acetylcholine, nicotinic acetylcholine receptors, which are in the membrane. When acetylcholine binds, obviously they let in sodium, etc. Okay? For the non-depolarizing, we block it here. Okay? The non-depolarizing bind to the receptor, and acetylcholine cannot bind. Okay? Therefore, any kind of signal is just blocked. Right? For the depolarizing, we do the opposite. So we put, for example, succinylcholine is one example. Okay? Succinylcholine. So we put something that looks like acetylcholine to sit here, and it just sits there. Okay? It's not removed. Therefore, the channel is open all the time, this one specifically. It depolarizes the membrane all the time. But this is not enough to cause contraction. Basically, we need some voltage-dependent sodium channels. We need the calcium channels, the dihydropyridine receptors. Okay, all these ones have to be activated by the depolarization in order to cause contraction. But all these other ones, after a few milliseconds, they just close. And they need to be what scientists call reprimed. Okay, so they have to be put back into the initial state in order for them to open again and continue with the contraction. Okay, and by keeping the membrane depolarized all the time, we block that. So in the end, the muscle becomes paralyzed. Okay, yes?
It's two different ways to sedate, or the sedation works the same way on both types, but it's two different ways of stopping the sedation.
Correct. It's not really sedation, okay? It's muscle relaxation. Sedation is a very different thing. So it's a muscle relaxation or complete paralysis. We can call it muscle paralysis because that's what it is. And correct, use two opposite ways to get to the same result in the end.
Is the first one inverse agonist or antagonist?
It's an antagonist.
What does alcohol do? Does it also
No. Okay, alcohol and a lot of general anesthetics, they act on GABA A receptors. So they bind, again, allosterically to GABA A. That's why I said the GABA A is a sort of a multi-receptor. It seems to bind all sorts of things, okay? And ethanol looks like the main effect is through GABA A, through potentiating GABA A receptors. Okay? I'm not sure what's your association with alcohol, but okay, fair enough. Okay.
Can you please explain what the difference was between the peripheral and the central?
Yep. So the peripheral, they act on the neuromuscular junction. So at the at the lowest level possible. Okay, it's these things influence the transmission of signal from the nerve to the muscle. The central ones act at the highest possible level. Okay, so they just influence the regulation, the normal regulation of muscle tone in our body. Okay, and they just make it less so. They decrease muscle tone. That's basically their function. Okay, so if you take this, you'll just feel more relaxed, and if your back is cramping up, it will probably improve that. If you take these ones, you stop moving, you stop breathing. Okay.
Yeah, actually, my question.
Okay. Right. Okay. Any questions about muscle relaxants? Okay. Let's. Move on. Oh, we should have a break, shouldn't we? So, do you need a break? Raise your hand if you do need a break. Okay, let's take. Okay. All right. Okay. It's going to be on the video anyway. So. Right. What? Okay, we're going to move away from nerves and muscles, and we're going to move to the cardiovascular system. Okay, so moving from acetylcholine, most of what we were talking about was acetylcholine and just basic nerves. We're going to move towards catecholamines, and we're going to be talking about the cardiovascular system, how that's regulated. Do you want me to open a window or something? Yeah. Okay. Right. Probably the largest group of drugs that are used to treat cardiovascular disorders are antihypertensive agents. So those are drugs that treat high blood pressure, okay? So antihypertensives. Okay, hypertension means high blood pressure. Okay, hypertension, high blood pressure. Antihypertensive agents. Right, knowing what you know about signaling, especially catecholamine signaling, we talked about which receptors are responsible for increasing blood pressure. Which receptors would you target if you wanted to lower a person's blood pressure?
Alpha-1.
Okay, so one possible target are alpha-1 adrenergic receptors. Remember, those are the activating receptors on the smooth muscles of blood vessels. Not all of them, but many of them have them, okay? And their activation causes vasoconstriction. So we would use what, an agonist or an antagonist? We would use an antagonist of alpha-1 receptors, or what is usually called an alpha-1 blocker. Okay? I think this is a confusing nomenclature because these things don't actually block the receptor. There's actually nothing to block there, okay? These aren't ion channels. But anyway, this is what you often find, okay? Alpha blockers, okay? But they are antagonists on alpha-1 receptors, and the antagonism will mean that the normal stimulation of the vascular tone will decrease, okay? Because we constantly, I mean, that's another answer to whatever question there was, whether they are inverse agonists. Well, they aren't, because in the blood, constantly, we have a certain amount of adrenaline, noradrenaline. So these, you know, even if you're not a hypertensive patient, these receptors are being stimulated all the time, okay? Maybe the stimulation is not very high, but they are stimulating. They are being stimulated. So if we use an antagonist, we will actually cause vasodilation. Not because these are inverse agonists, but because we remove the constant stimulation that we get anyway. Does it make sense? Does it make sense? Okay, all right. Okay, so alpha-1 blockers are definitely a way to decrease blood pressure. I want you to remember one of them, prazosin. There are many more, okay? So this is one way to block the activity of catecholamines on the smooth muscle and blood vessels by blocking alpha receptors. What other receptors can we block to decrease blood pressure?
Beta.
And which beta one? Beta? Which beta receptors?
1.
Okay. Did anybody suggest beta 2?
Agonists.
Yeah, we could do. Well, I'll get to that, okay? So one way would be, once again, blocking or antagonizing beta 1 receptors. Once again, remember, beta 1 are mostly expressed in the heart, and there they increase heart rate, they increase the strength of contraction, etc. Okay? So by antagonizing beta 1 receptors, we decrease the heart rate, okay? We decrease the strength of contraction, and by that, we decrease the amount of blood that is pumped into the circulation. Okay? And since the circulation has only a certain volume, if we decrease the amount of blood that is being pumped out, okay, over a period of time, that means that the pressure in the circulation is going to go down, right? It's the same thing if, you know, if you have a hose and you just pump less water into it, the pressure in the hose is going to be lower, right? Yeah? Yes?
Is a beta antagonist and a beta blocker the same?
Yes, they're also called beta blockers. Yeah. Beta blockers. Okay. Now here I say alpha 1, beta 1, but usually what you find is just alpha blockers and beta blockers. Okay, and I'll probably explain it as well. So one of the first beta blockers was called propranolol. Propranolol. And that was a non-selective beta blocker. So it wasn't selective for beta 1 receptors. Well, it wasn't. It actually still exists. It's not a selective beta 1 blocker. It blocks all beta receptors. Okay, which is fine for most people, but people who suffer from asthma, and remember we talked about the role of beta 2 receptors in the relaxation of smooth muscle in the bronchi. Do you remember that? Okay, so if we block beta 2 receptors, we increase the probability that the bronchi will actually constrict. And in people who suffer from asthma, that could be a problem. It could provoke asthma or it could make it worse. Okay? So non-selective beta blockers are basically fine for most people. But for people who suffer from asthma, you have to use selective beta 1 blockers. Okay? And we do have those. For example, atenolol is the one that I want you to remember. Atenolol is a selective beta 1 blocker. So you can use it for patients who have asthma. Yes?
And which beta did it bind to make the contraction of the throat?
It's not the throat, it's the bronchi, okay? It's in the lungs. Beta 2. If you block beta 2, you make it more likely for the bronchi to contract. Again, in healthy people, it's usually not a problem. In people who suffer from asthma, that could be a problem. Okay? So we have beta 1 selective ones. Yes?
What was that again?
Atenolol is a beta 1 selective blocker or antagonist. Okay? And since we talked about partial agonists, here's a partial agonist for you called pindolol, which is a partial agonist on beta receptors. Okay? So once again, remember we said that partial agonists act as agonists when there is very little of the real agonist. But as the concentration of the agonist goes up, they start acting as antagonists. Okay? And that is exactly what we're trying to do with pindolol. Basically, we want to keep a certain stimulation of the heart, even when there is actually not a lot of adrenaline in the bloodstream. But as the amount of adrenaline and noradrenaline in the bloodstream goes up, we want to limit their effects. We want to decrease their effects. Okay? So what pindolol can do to some extent is basically to decrease the extremes. Okay? The too low heart rate and too high heart rate. Okay? It's a big simplification because pindolol is a bit of a weird molecule, but this is your example of a partial agonist. Okay? Yes, there was a question?
Selective or non-selective?
It's a non-selective partial agonist. Okay.
Do you mind closing the window, please?
Oh, no problem.
Thank you very much.
Well, you have another one then. Okay, just going back to the suggestion of beta 2 agonists. Okay, that would probably make some sense if you had a specific beta 2 agonist that you would dilate blood vessels at least in part of the body. Okay, they're not, however, clinically used because in fact. Well, they are clinically used, but for other things. They're actually used for the treatment of asthma. Okay? So if you see people with inhalers who have asthma, not always, but sometimes they contain beta 2 agonists. Okay? Because we want their bronchi to dilate because they're having asthma. Okay, I think I've lost you now. So, does everyone understand what I'm saying about beta 2 agonists? Okay, they are used to treat asthma because their activation relaxes smooth muscle in the bronchi, and that's what we want because asthma means that the bronchi are constricted and they can't breathe. Okay, now what do they do with the blood pressure? Well, not very much, but those of you who may suffer from asthma, if you actually inhale the beta 2 agonist, your heart rate goes up and it's actually not all that pleasant. So they probably wouldn't work for antihypertensive agents. Yes?
Don't the inhalers have cortisol in them?
Depends. Okay, depends what you're trying to do. Those inhalers that you only use when you have asthma attack, usually they have beta-2 agonists. The ones that you use all the time to basically decrease the inflammation in your lungs, they have corticoids or some other drugs. Okay, so that's what I was trying to say. It's not every inhaler that contains beta-2, but some of them do. Right. We've now talked, I mean, we started with antihypertensive agents, but since we mentioned alpha blockers, alpha-1 blockers, and beta-1 blockers, the question is, can we also use agonists of these receptors for something useful? Okay, so we talked about antagonists, and we said that they both are antihypertensive. And the question is, well, can we use alpha-1 and beta-1 agonists to do something interesting? Well, turns out we can. What are alpha-1 agonists going to do? What are they going to cause in the body? They will increase blood pressure, absolutely. By causing vasoconstriction, okay? Now, the alpha-1 agonist that is used clinically to increase blood pressure is the natural agonist, is noradrenaline, okay? So if you have a patient that has a very severe hypotension, especially in intensive care, what do? You give them noradrenaline. Okay, that's the usual. So the synthetic alpha-1 agonists that I'm going to talk about are not used in this setting. But they are used extremely widely as nasal decongestants, nasal decongestants. So those are the sprays that you have stuffed nose, okay? Those sprays contain alpha-1 agonists. How does it work? Well, if your nasal mucosa is inflamed, it swells, okay? And the swelling is caused by the dilation of blood vessels, okay? So we use an alpha agonist to constrict those blood vessels so that you can breathe through your nose again. Okay? And the two probably well-known ones are phenylephrine, and let's say oxymetazoline. There are hundreds of those, well, not literally hundreds, but there are lots of those molecules. So if you look at your nasal spray that you use, you'll find some of these azolins, they're nafazolin, lots of different ones, okay? But these all are alpha-1 agonists, and their role is to constrict blood vessels in your nose so that you can breathe through it again. Okay? Yep. Decongestant, do you want me to run? Okay, decongestant meaning that it decreases congestion in your nose. Okay. Decongestant. What about beta-1 agonists? What would those do? Yes?
Vasodilation. In the beta-1.
Beta-1. Okay, we already talked about beta-2, which are used for asthma treatment. But what about beta-1? They will increase heart rate. They will increase the strength of contraction. Okay, these agonists are used for very short-term, basically strengthening of heart action. Okay, so if you have very acute heart failure, you would use a beta-1 agonist to basically whip the heart into working harder. Okay? But this can only be used for a very short period of time because obviously the heart will not take that forever. Okay? So beta-1 agonists are not used for chronic heart failure. But in acute cases, where for some reason the heart is just not working hard enough, we can use beta-1 agonists just to whip it a bit more. Yeah.
And if you have like heart fibril,
fibrillation.
Will you use an antagonist?
For a fibrillation, no, you wouldn't. You would do electrocardioversion, really. For arrhythmias, you could use, when we talk about local anesthetics, so you could use lidocaine to block the arrhythmia. But for a ventricular fibrillation, there's nothing else you can do. I mean, you have to use the electric current.
Okay, maybe not fibrillation, but I know like old people sometimes have problems with their heart, that the heart doesn't...
Yeah, well for that, use beta blockers. Okay, if you want to decrease heart rate, which is normal rhythm, okay, it's not an arrhythmia, it's just very high, it's tachycardia, so very high, use beta blockers. And actually beta blockers are you could say, abused rather than used by a lot of people who are anxious before a performance, okay? Because often the symptom of being anxious is that your heart rate goes up, and it makes you even more nervous because your heart rate is, because your heart is pounding. So even like people who perform music or something, some of them take beta blockers at low doses because it calms them down, because the reaction of the body on being anxious is blocked by it, okay? But this is not something I would recommend because there are potentially quite serious side effects, but I'm just saying that it happens, okay? So indeed, if you want to decrease heart rate, you absolutely use beta blockers for that, okay? Right, so beta-1 agonists you would use if you want to, tell the heart, okay, let's get going, okay, you have to go harder than you're doing at this moment. The two that I want you to know are dobutamine and isoprenaline. They are in your tables anyway, dobutamine, okay? Only usable for a very acute intervention, okay? Over a long term, it just damages the heart, okay? You can't use them for a long term. Yes?
For the things that you're saying, I want to know both of them.
Oh, either of them, okay? One of them. But those are the two that are in the table. That's what I was trying to say. Yes?
Yeah, because I was wondering about that. On the previous test, there's been random questions where there are one of them in place, and if you then know the other,
really?
It could be
Okay. Well, at least you need to know one of them. You need to know at least one of them actively. If I ask you, what is a beta-1 agonist? You have to have at least one. You have to know at least one. Okay?
Are you going to ask that?
We'll see. But it might be advantageous to know more of them passively. But once again, what I say, you have to distinguish what is essential to pass, knowing one of them, and would improve your grade, knowing both of them. Okay? So the more you know, the more likely you get a good mark. Okay? But I want to stress what is essential, what you must know, and that is knowing one of them. Okay? Good.
So we're going to get that on the short answer part?
It might be there, yes.
Yeah.
It's one of the things that might appear there.
Okay.
Yeah.
Nice.
Okay. Right, to finish off this whole group of antihypertensive drugs, and I know that we actually moved away from antihypertensive drugs because these aren't antihypertensives, but I'm going to finish off the antihypertensives by another fairly large and fairly widely used group of antihypertensive agents, which are calcium channel blockers. Calcium channel blockers. Okay? There the mechanism is probably fairly obvious. Remember that smooth muscle, and to some extent cardiac muscle, requires extracellular calcium for it to contract. Okay? Unlike skeletal muscle, which gets all the calcium that it needs from the inside. Okay? So smooth muscle, to some extent cardiac muscle, needs extracellular calcium in order to properly contract. Right? So if we block the calcium channels on the membrane, we can decrease the either heart rate or the strength of contraction or the contraction of smooth muscles in blood vessels. Does it make sense? We use calcium channel blockers, we relax blood vessels, and we can decrease the activity of the heart by a similar mechanism because they both need extracellular calcium in order to contract. Okay? So this is what calcium channel blockers are for. Blockers. Some of them act more in the heart, and some of them act more in the blood vessels, but all of them act pretty much in both of these tissues. And by causing vasodilation and by decreasing the heart rate and the strength of contraction, we decrease the blood pressure.
So they do not work in skeletal muscle?
They do not work in skeletal muscle. Okay, they have no effect there. So they will not paralyze you or anything like that. Okay? Okay? Yes?
Do they control, are they used to increase
heart rate or to
decrease.
Decrease heart rate or the strength of the compression?
They do all of that, okay? And as I said, some of them are more selective for blood vessels, for the smooth muscle, and some of them more for the cardiac muscle. And that also basically, you can choose the right one for your specific patient, but that's going far beyond what we should discuss today. Yes.
Why did they not affect the skeletal muscle?
Because the skeletal muscle doesn't need any outside calcium for it to contract. It does have calcium channels, voltage-dependent calcium channels, which do bind some of these calcium channel blockers. But these blockers are actual blockers, so they block the pore, okay? But in the skeletal muscle, you will recall that we only need a conformation change in the channel. We don't actually need any calcium to go in, right? That's the reason. Okay. Okay, very briefly, we can also use, remember that nitric oxide causes vascular relaxation, okay, the relaxation of the smooth muscle in blood vessels. So we can use chemicals that produce nitric oxide to decrease blood pressure as well. And they are quite widely used to very quickly and very efficiently decrease blood pressure. One famous one is nitroglycerin, which you've probably heard of, an explosive thing, but actually can be used to dilate blood vessels and also decrease blood pressure. And there are many other nitrates, so the group are nitrates, which can be used for that. Okay, I'm not mentioning the calcium channel blockers. We don't really have time for that, but they're all in your handouts. Yep. Yes. Yeah. I mean, nitroglycerin especially is mostly used to dilate blood vessels in the heart, so coronary arteries, but it will actually dilate many other as well and will decrease blood pressure as well. Yes, but that's.
It will inhibit CMP phosphodiesterase? Does it inhibit CMP phosphodiesterase?
No, it produces nitric oxide, so it activates guanylate cyclase. Okay? Yeah. If we had 2 lectures, I would talk about the inhibitor of phosphodiesterase, which is sildenafil Viagra, which also works in a similar way, but a completely different mechanism. Okay. The next bit I wanted to talk about, but we'll really make it super brief. Maybe I don't have to. Okay, are antihistamines. So drugs that influence, that block the transmission of signals by histamine. So antihistamines. I know we're jumping from one area of the body to another, but the reason is, or the organizing principle is that I want to go through the neurotransmitter systems, the signaling systems that we talked about, okay? So we're jumping from cardiovascular to antihistamines, but the reason is that I wanted to talk about catecholamines and I want to talk about histamine, okay? So what are antihistamines used for? I guess many people have heard of them before. Okay, so usually when you come across an antihistamine, it's used for an allergic reaction, okay? If you suffer from allergies, you would take antihistamines to block that, okay? Now these kind of antihistamines are in fact H1 antihistamines. So they are specific antihistamines. They're specific for H1 receptor, which is the receptor that is responsible for mediating allergic reactions, okay? So we're talking about histamine H1 receptors in the periphery. These are not central receptors, okay? In the periphery, immune cells, smooth muscles of blood vessels, etc., have H1 receptors, and these take part in mediating allergic reactions, okay? All the symptoms that you get are, most of them are mediated by histamine through H1 receptors. So we use antihistamines for that. The first generation of antihistamines, they were still able to cross the blood-brain barrier. So they also acted, we wanted them to act in the periphery, but they were also acting centrally. And we said that histamine, part of the role of histamine in the central nervous system is regulating sleep. That meant the crossing of the blood-brain barrier of these old antihistamines meant that people were sleepy. Okay? So antihistamines, the old antihistamines used to cause quite severe sleepiness, okay? They actually worked as sedatives or hypnotics. Some of them still are used as a hypnotic agent. You take an antihistamine, you just fall asleep. Yep.
Is that why when you take a vaccination for allergy, you kind of get sleepy and drowsy?
No. Okay, vaccinations are a completely different thing.
But for allergy vaccinations?
Yeah, but a vaccination is not a drug, okay? It does completely different things to your body, okay? But these are old antihistamines, which many of you have probably never heard of, but they used to exist, and people used to be very sleepy, okay? That's why if you buy antihistamines, maybe in the US, maybe in the UK, they say non-drowsy. So that means that the second generation, okay, they no longer cross into the brain, and they don't cause drowsiness. Yes?
Cough syrups, are they the same thing?
Sometimes they contain the old antihistamines because the general sedative action of these antihistamines can stop coughing as well, at least decrease. They're not very effective, I don't think. I think there are much better cough medicines than that. But yes, some of the formulations do contain these old antihistamines. Okay, so first generation antihistamines, cross blood-brain barrier, cause drowsiness, very effective, but they cause these side effects. The new generation have other side effects, but not sleepiness, okay? But we also have H2 receptors, and remember we said H2 receptors are mainly present in the gastric mucosa, in the stomach, where they regulate the production of hydrochloric acid, okay? Where they stimulate it. So by having H2 antihistamines, by blocking H2 receptors, antagonizing them, antihistamines, we can decrease the production of hydrochloric acid in the stomach, which was used and to some extent still is used to treat gastric ulcers, peptic ulcers. Okay? By decreasing the production of acid, we decrease the damage to the stomach lining by this acid, and therefore we can help the ulcers to heal. Okay? Nowadays, H2 antihistamines are generally just sold over the counter, so without a prescription, for people who have heartburn or dyspepsia or something like that. So H2 antihistamines are almost never today used to treat gastric ulcers. Do you know what is used to treat? What do we give to patients with gastric ulcers now? Well, this is ranitidine, okay? So ranitidine is an H2 blocker, ranitidine. Yeah, but the treatment of choice is that we assume that the bacterium is there, which is called H. pylori, Helicobacter pylori, Helicobacter pylori, which was discovered in late 80s that it's associated with gastric ulcers. So nowadays, the number one treatment, the treatment of choice for gastric ulcers is an antibiotic. Okay, so usually you take an antibiotic. There are several different possibilities. And you take something that is called a proton pump inhibitor. Proton pump inhibitor. So blocking H2 receptors decreases the release of acid by some regulatory pathways. But what we can do, we can directly block the enzyme that pumps the protons, that secretes hydrochloric acid, which is called proton pump. And the inhibitor is called proton pump inhibitor. Okay, so this is the current treatment for gastric ulcers, just so you know. Okay, proton pump inhibitors are incredibly effective. Yeah, like you take one and 10 minutes later, the pH in your stomach is 7. They are incredibly effective. They just completely block any production of acid. So this is currently what's used. But anyway, H2 antihistamines, they are important for understanding this whole histaminergic system, but also they're still sold over the counter for, especially for heartburn, okay? For gastroesophageal reflux. Right. Okay, and we have 15 minutes for all of psychopharmacology. So that's going to be fairly compressed, but I'll try to tell you about the main groups and how they work.
We have no classes afterwards.
Sorry?
We don't have any classes afterwards.
Yeah, but I mean, I don't want to keep you forever. But the old video, the old second video, should have more information on those things. Okay.
Are serotonin catecholamines?
Serotonin?
Yeah.
No.
Okay, why in one of our histology lectures they're mentioned under catecholamines?
Well, maybe they made a mistake. They're definitely not catecholamines. They are, in many ways, they are similar to them. The synthesis is quite similar to the degradation, but they're definitely not catecholamines because they don't actually contain the catechol ring. Okay, they can't be catecholamines. Okay. Right. Okay, psychopharmacology. I'm going to talk about two main, let's say, groups of diseases, of psychiatric disorders. The first one is going to be about depression. Okay, depression. It sounds like one disease, but there are several different forms of depression. Does anyone know what depression? What the symptoms of depression are?
Can't sleep.
Us right now.
No sleeping and no appetite.
Okay, loss of appetite, absolutely. Insomnia, very typical. Yes.
No sexual desire.
Okay, yeah. Loss of libido, absolutely.
Motor retardation.
Could be, yeah. People are slowed down. It's very difficult for them to find motivation to actually, even step out of bed in the morning. I know we all have that, probably most of the mornings, but that doesn't mean we have depression. But yes, absolutely, that's an important symptom. Yeah.
On social behavior?
In what way?
You just pretty much stick to yourself.
Yeah, okay. You don't want to meet people, absolutely. You don't want to talk to people.
Showerless.
Yes, could be. Yeah, that's the loss. That's the loss of motivation. You're not motivated. Could be. Yeah. Yeah. So that's all true. A very common, a relatively common symptom of severe depression are suicidal thoughts. Okay, so people basically feel so bad that they want to kill themselves. What I didn't hear, but it's an important aspect of it, is pathological sadness. Okay, so that's the psychological part of it. So all the other symptoms that we talked about, we can observe pretty much, but the sadness that people feel, we can't observe. We have to ask them. Okay, but pathological sadness is a big part of depression. Not all depressed people feel sadness, but it's a typical characteristic of depressed people. They feel pathologically. Now, when I say pathologically sad, if your ferret dies or if your hamster dies, you're going to be sad, but that's not depression. Okay, but if the sadness is incomparable to the stimulus, or more often there is no stimulus, nothing happened, you just become pathologically sad. Those are symptoms of depression. You can also be deluded. You can have delusions in very severe depression. So, do you know what delusion is? Anybody? Delusion? Huh? No, it's not really.
Things that are not happening.
Okay, believing incorrect beliefs, basically. Okay, so often they are quite bizarre. So, people with depression, perfectly intelligent people with very severe depression, can, for example, believe that they caused the death of millions of children. Okay, that's a depressive delusion. Okay, and it's something you can't argue about. Okay, it's not something you say, "Oh, of course not." Okay, or something. "Oh, well, how would you do it?" It's just a very deeply felt belief, and there's nothing they can do about it. And you can see how they could cause suicidal thoughts. So anyway, it's a very brief introduction to depression. It's a very complicated disease. There are many different forms, etc. Now, the treatment of depression actually predates, and you're going to see that that's a recurring pattern in psychopharmacology, predates the understanding of what depression is actually about. Okay, so first people discovered, mostly by accident, drugs that can treat depression. And then, based off what these drugs actually do, they started thinking, oh, okay, so maybe depression has something to do with these neurotransmitters. Okay, so it didn't work that first we understood, or people understood what depression is about, and then they started thinking about drugs. It was the other way around. And you'll see that, as I said, in psychopharmacology, that's a common pattern. The first drug, I'm not going to talk about the first effective drugs because those were amphetamines and it's a very controversial topic. But the first group of drugs that is still used today were inhibitors of monoamine oxidase. So inhibitors of monoamine oxidase. They were discovered by accident when people were looking for a new treatment for tuberculosis. They discovered a drug that was called iproniazid, which was meant to be a very useful, you could say antibiotic, but chemotherapeutic agent against tuberculosis. They gave it to patients, and they noticed that their mood significantly improved. You have to realize we're talking about late 40s or mid 40s and late 40s, 1940s. Then tuberculosis was very often a deadly disease. Okay, so those people were spending many, many years in sanatoriums, and they were being treated, and many of them knew that they're going to die. So they were actually chronically depressed. Many of them were chronically depressed for obvious reasons. So they gave them this new drug, and they noticed that their mood improved. So then psychiatrists noticed and said, oh, well, maybe we can use it to treat depression. Many years later, they discovered that these drugs inhibit monoamine oxidase, and that was one of the reasons why the first hypothesis of depression started to be formed, which is called the monoamine hypothesis. Monoamine hypothesis, which just says that depression is caused by low levels of monoamines in the brain. Now, what are monoamines? Okay, and which neurotransmitters are monoamines? Serotonin? Dopamine? Okay, so catecholamines and serotonin are all monoamines, okay? And we know it because they are all metabolized by monoamine oxidase, okay? So monoamine hypothesis means it says depression is caused by low levels of serotonin and catecholamines in the brain, okay? Very soon after monoamine oxidase inhibitors, another group of antidepressants was discovered, which are called tricyclic antidepressants, or tricyclics. The name just says that they have 3 cycles in the molecule, okay? That's all it means. Now, tricyclic antidepressants, again, were discovered by accident. They were looking for other things and noticed that again, we're in late 40s, so these two actually are very closely related in time. Tricyclic antidepressants were discovered, noticed that they help against depression very effectively. And only much, much, much later it was discovered that all these tricyclics inhibit the reuptake of monoamines. So these are non-selective reuptake inhibitors. Okay? They just inhibit non-selectively the reuptake of catecholamines, serotonin, and to some extent dopamine as well. Okay? Very effective drugs, but their problem is that they are quite severely cardiotoxic. So if you take a higher dose, if you overdose yourself on tricyclics, it damages your heart, and it damages it in such a way that it's very difficult to treat it, okay? So if taken at appropriate doses, they're completely fine, very effective. But if you take too much of them, they are very, very dangerous. Now, obviously, if you're treating patients that have suicidal thoughts, giving them, a bottle with tricyclic antidepressants that they can actually very easily use to kill themselves is not ideal. Okay, so nowadays tricyclics are only used in patients who are not suicidal. Okay, and actually they're used less and less nowadays because we have much less toxic drugs that we can use. Also less effective, but yeah.
When the signals are taken up, do they then bind and dissociate to the receptors over and over again?
Absolutely.
Or do they constantly bind?
No. Basically what we do by inhibiting the reuptake, we just increase the concentration in the synapse, okay? So the neurotransmitters are there, and they can bind and, and detach and bind and detach, but it just the time they spend on the receptors is higher than if we taken them up into the presynaptic neuron. Yes?
Doesn't that increase the monoamine?
Well, exactly. The hypothesis says that depression is caused by decreased activity of monoamines. Okay? If we have too little monoamines in the brain, we have depression. Okay, that's the hypothesis. Extremely simplified, but that's the hypothesis. So the idea is that these drugs increase the amount of monoamines on the synapse, and therefore they treat depression. Yes?
I was just wondering, can this lead to desensitization, or?
It actually does,
Yeah.
but I'll comment on that when we finish this, because there are actually quite significant problems with this hypothesis. Okay, but anyway, let's move on from tricyclics to the more selective, to the much less toxic drugs, which are selective reuptake inhibitors, and specific serotonin reuptake inhibitors. Okay, so these are drugs that only inhibit the reuptake of serotonin. They are practically non-toxic. Okay, you cannot kill yourself with them, pretty much. Okay, you would have to like choke on them or something. Okay, so they're very low toxicity, and therefore they are extremely widely used. Basically, you know, they are the drug of choice. They are significantly, even though the pharma companies say otherwise, but mostly they're much less effective than the tricyclics, than the old ones. Okay, but they still work, and they have no toxicity, so you know, just anybody can prescribe them, and you don't have to worry about people killing themselves with them. I mean, they can still kill themselves in another way, but they can't poison themselves with these. So SSRIs, hugely widely used. Prozac, well-known Prozac is one of them. Okay, so it was a phenomenon in the 90s when these drugs started to be marketed.
What could be some of the different reasons for the lack of?
Yeah. Okay, I'll try to answer that. Okay, in addition to SSRIs, we also have SNRIs, which is sort of a return to the tricyclics. The N stands for noradrenaline. You don't have to know that. Okay, just this is additional knowledge. So there are some new drugs that try to inhibit the reuptake of both serotonin and noradrenaline, but not be tricyclic, so non-toxic. But that's a different thing. Okay, what is the problem with the monoamine hypothesis? It sounds great. But the problem is that if you give a patient, yes?
Excuse me, do the selective reuptake inhibitors inhibit reuptake of serotonin?
Correct. Okay. Yes. So selective serotonin reuptake inhibitors, they inhibit selectively the reuptake of serotonin. Okay? The problem is that you have a patient with depression, you assume that the amounts of monoamine transmission in the brain are too low, so you give them a drug. And basically immediately, after you give them either monoamine oxidase inhibitor or SSRIs or tricyclics, immediately the transmission on the synapse goes up. Okay? So the amounts of serotonin or catecholamines in the synapses go up within a few hours. But the antidepressant effect of antidepressants usually takes several weeks to develop. Okay? So usually you have to take them for a fortnight, 3 weeks to actually feel the effects. The question is, well, if the problem is in the transmission, why doesn't it improve immediately if we know that the transmission improves immediately? Well, that's a question to which people don't know an answer. So, yeah, there's a desensitization of receptors. There are a lot of things going on in the target neurons. There's a reprogramming of transcription, etc. There are lots of things happening, but people don't really know. Okay?
I was just wondering, if you have too much serotonin, can that have the same effect as, for example, the sarin, the poison?
Oh, no.
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 In the same way.
No, absolutely no. No. Also because there is no real I mean, yeah, it does not happen.
Yeah.
Okay. Mm-hmm.
So if serotonin binds to a receptor, you don't have to like downgrade it to make the signal last?
Yeah, I mean...
It has to be downgraded to keep most of the...
Oh, yeah, I mean, that's the same question. Like, if we don't get paralysis of the serotonin... Yeah, I mean, first of all, the inhibition here is not complete, so there's still removal, there's still some removal of the signal. So you just make it a bit stronger, but you don't like completely block the removal, okay? So it doesn't seem to cause that problem. But there is a downregulation, there's a gradual downregulation of those receptors, and that's probably part of the effect. It looks like it's not really so much about the amount of neurotransmitter in the synapse, it's more about the downregulation of the receptors afterwards. It's a complicated area, and we don't have really time to look into that. In your 4th year, I think, when you start psychiatry, you can talk about the neurobiology of depression. All right. So the second group, and probably the last group that we have time for, are antipsychotics. So these are drugs that are used to treat psychoses. Do you know any psychosis?
Sorry, what were these?
Antipsychotics. These were antidepressants. Antipsychotics. Do you know any psychosis? Okay, schizophrenia, typical one. There are many other ones, okay? Schizophrenia. Okay, we don't really have a lot of time to talk about the symptoms, so I'll, okay. Typical symptoms are, they can be divided into positive symptoms and negative symptoms. The positive symptoms are when you add something, okay, something is added. Usually there are hallucinations and there are delusions, okay? So those are the things that schizophrenics have more than other people, okay? That's why they're called positive symptoms. Not that they're nice to have them, but they are added to it, okay? So delusions and hallucinations. But there are also negative symptoms where something is removed from the patient. And that is usually the social behavior, social contacts, also cognitive abilities, okay? Often long-term schizophrenics tend to lose their cognitive abilities, so abilities to think, you could say intelligence to some extent, okay? So these are negative symptoms. Anyway, a large group of disorders, very interesting. As usual, the first drugs for schizophrenia were discovered by accident. They were actually trying to find new antihistamines, and specifically new antihistamines for cooling down patients. In the Second World War, obviously there were a lot of injured soldiers, and not all of them could be operated on immediately. And since, as they were bleeding and losing blood, etc., the only way they could do is to cool them down a little bit so that the loss of blood wasn't as damaging as if they were at normal body temperature. So they started discovering these chemical cocktails that would allow the body to really calm down, slow down, cool down, okay? And they were looking for new antihistamines for that. And then they noticed that these patients were really incredibly sedated with this new drug, with this new chemical. And they were thinking, oh, well, we also have psychotic patients in our, then called insane asylums or what have you. And we could use this new drug to sedate them, okay? So it wasn't really about treatment. It was just about having less work with the patients who often are, need a lot of attention. Today it's horrible, but that was the thinking then, okay? So we use this great sedative, they still call it a sedative, and we give them to the patient. Now, it worked, because these drugs are so potent that they will sedate anybody. But interestingly, they noticed that apart from calming the patients down, so sedating them, the patients started saying, well, I still have, the delusions, I still have the hallucinations, but actually they don't affect me as much. Okay? Because the typical thing is these, the schizophrenics or patients with schizophrenia would often have fairly bizarre delusions, or from our point of view, fairly bizarre delusions or hallucinations, but they are extremely affected by them. So it's not like, oh, I was going to work and I met the devil and it was fine or something, okay? No. It's for them, it's extremely, it really consumes their emotions. It's really a horrible state. So all these delusions are really, how to say it, they are a huge part of their everyday lives, okay? Now, what happened when they started giving these new drugs, suddenly the patients were saying, well, yeah, I still meet the devil, but I don't care very much anymore, okay? Which sounds like fun, but it's a massive improvement, okay? Because yeah, if you keep seeing the devil and it doesn't really affect your everyday work, well, then what's the problem, really? So this was the first idea that maybe this new drug could do something more than just calm the patients down, that it could actually treat something about the disease. It doesn't mean that it cured them, but it treated something very fundamental about the disease. The drug that we're talking about is called chlorpromazine. Again, developed for other purposes, but this is the first antipsychotic. It was then caused, either you would call it a major tranquilizer, which is you don't have to remember that, that's a very old name. I'm just writing it down because Czech students asked me about this terminology. So major tranquilizer. Tranquilizer? A sedative, okay? It makes people tranquil. Okay, so major tranquilizer meaning it's a super effective tranquilizer. Okay, the next name was it was a neuroleptic. Neuroleptic. Okay, so these drugs used to be called neuroleptics. Nowadays they're all called antipsychotics, but I'm just showing the older names because you may still come across them. Okay, so chlorpromazine was the first one. Many others were developed. For example, haloperidol. Chlorpromazine is no longer used today, but haloperidol, which comes from mid-60s, is still used clinically. It's a super, very, very effective neuroleptic drug or antipsychotic drug. So once again, first we had the drugs, and then we started looking at what do these drugs actually do. And based on what these drugs were doing, various hypotheses of schizophrenia, of psychosis were developed. Nowadays, the most, let's say, accepted hypothesis is a dopamine hypothesis. Dopamine hypothesis. And it is based on the fact that most of these super effective antipsychotic drugs are antagonists on dopamine receptors, and most of them are antagonists on D2 receptors. Not all of them, but most of them. Okay? So the thinking was, okay, we have a patient with schizophrenia, we have no idea what's going on in the brain. But if we give them drugs that bind to dopamine receptors and block them, these people get better. Therefore, schizophrenia has to have something to do with dopamine, right? That was the thinking. And it still is, because the dopamine hypothesis is still the most dominant hypothesis. Yes?
Why does atypical antipsychotics work then?
Well, that's what I was just going to talk about that. The problem with the dopamine hypothesis is that we have drugs that are very effective antipsychotics, but they do not bind to D2 receptors at all. Okay? They are so-called atypical antipsychotics. So they're atypical because they don't bind to dopamine receptors, but they are still effective. And the question is, well, how is that possible? Okay? So I'll just leave it at saying, well, it's likely that schizophrenia has something to do with the dopaminergic system, mostly the mesocortical, so the one that projects into the cortex. But we don't really know the details, okay? It's clear that serotonin probably plays a role there, that glutamate plays an important role there, etc. Okay? I think in the second lecture from last year or the year before, I think I talk a bit more about the glutamate, the role of glutamate, but this is all basically you need to know at this point.
These block the dopamine receptors?
Yes, they're antagonists on dopamine receptors, primarily D2. Haloperidol is a pure D2 antagonist. It doesn't do anything else. It only blocks D2, and it's very effective against, well, schizophrenia.
But all three of them block the D2 receptor?
Say again?
All three of them block the D2 receptor?
Some of them more, some of them less, some of them not at all. Clozapine, the atypical one, doesn't block D2 at all.
But most of them do?
Most of them do have activity on D2 receptor, yes. Okay. The last thing, there are quite a few things that we didn't quite manage to fit in, but that's just the way it is, okay? I'm sorry, but we only have one lecture. But I'll just mention about the side effects. What are the side effects of neuroleptics? Because clinically they are very important. Okay, if you need to leave, you can leave. Does anyone need to leave right now? No? Okay, because I also need you to give you these. So, since the dopamine receptors don't only work in the mesocortical projection, but all the other ones as well, the neuroleptics, by blocking these receptors, not just D2, but mainly D2, will obviously disrupt all the other dopaminergic systems. Okay, and by knowing the systems, and that was the reason why I want you to learn those systems, because you can guess then what the side effects of antipsychotics are going to be. So can you guess? What will happen if we block, apart from the mesocortical projection, which is the one that we want, we block the transmission in all the other ones as well? Very good. So we'll basically cause, to these patients, we'll cause them Parkinson's disease. Okay? It's not Parkinson's disease because the cause is different, so it's called Parkinsonism or Parkinson's syndrome. But the symptoms are the same. Okay? So in Parkinson's disease, the dopaminergic neurons are dying, So we don't have any dopaminergic transmission, or we don't have enough. Here, by blocking those receptors, we basically mimic the same thing. The neurons are still there, but the signal doesn't go through because we block dopamine receptors. So and you will probably see when you start your psychiatry, clinical training, you will see patients on haloperidol, especially high doses of haloperidol, and they look exactly like Parkinson's disease patients. Okay, they move very slowly. They're slouched. Their faces are not moving very much. Okay, so you basically cause the same symptoms by a different way. So that's a very typical. They're called extrapyramidal symptoms, and they are quite unpleasant.
But does that actually cure the patient? Or
no, those are side effects. Okay, those are side effects. That we don't want to do that, but it just happens because we use these drugs that antagonize dopaminergic receptors.
So the remedy is worse than the disease.
Well, it isn't, but it's still unpleasant. Okay. Yep.
Does the atypical ones are they just as effective?
They don't have these side effects. Okay. So the ones. That's up for debate, okay? Haloperidol, by this very, very effective blockade of dopamine receptors, if you give a large enough dose to a patient who's never had them, basically they are completely paralyzed, okay? It's not a paralysis that they can't move, the kind of paralysis that curare does, but it's a central paralysis. You basically completely block their dopaminergic transmission in the basal ganglia, and they cannot move, which again is extremely unpleasant, so we want to avoid that. Okay, but it's so effective that you can basically paralyze the patient just by giving them high enough dose of of haloperidol, for example. Chlorpromazine, the same thing. What other side effects can we envisage looking at the other?
Excessive production of prolactin.
Absolutely. Okay, excessive production of prolactin. Again, a very common side effect, very unpleasant side effect, especially in men. The increased prolactin production causes the growth of breasts. Okay, it can start lactation in some, so it's a very unpleasant thing. Obviously, especially if you're suffering from a psychiatric disorder and suddenly your body starts changing, it's bad. Okay. But that's how it is. Okay. So these typical neuroleptics, those typical antipsychotics have these side effects. Now, the last one that we didn't talk about is the reward system. Does it have an effect on the reward system? Yeah, it probably does, but since the disease influences so much of the person's perceptions, it's not something that is usually studied, like, do you have less motivation? Well, yes, because you have schizophrenia, usually people generally have that. No, I mean, I didn't mean it in a bad way, but I'm just saying that it's part of the disease itself. So seeing whether those neuroleptics make it worse, maybe they do a little bit, but it's very hard to say. Okay, but the main two symptoms are Parkinson's syndrome, okay, and hyperprolactinemia. Okay, right. We could probably stay there for another hour, which I don't really want to do. So I don't mind doing it, but I don't think it's appropriate. So have a look at the other video if you're really interested. But the essential information that you need is in the handouts. If you need any more explanation to some of the terms or some of the mechanisms, just send me an email or ask on Viuka, and I can explain it for everybody or for you once again. Okay? So, right. If you have 5 more minutes, just please fill in these. Fill in these 4.